Welcome to the American College of Obstetricians and Gynecologists Video History Project. Today we're very fortunate. We'll be interviewing a major person as far as our specialty is concerned, who has crossed over many different barriers and many different ways to become an outstanding private practitioner, Dr. Sam Smith. Sam, thank you very much for being interviewed, and we appreciate having you here today.
My pleasure.
Let's begin a little bit with your history. Can you tell us where you were born and raised?
I was born and raised in Short Hills, New Jersey, the youngest of 9 children. Dad was the local doctor for Short Hills, and I grew up there and went to school in New York City from 3rd through 6th grade, the 5th and 6th grade by myself, commuting into New York City because I was too bright for the local schools but too dumb to go ahead of a class. And then went to the local high school and graduated from Milburn High School.
When did you decide that you would become a physician?
It wasn't until I was in college, because all growing up, what I wanted to be was an actor. I was in all the local high school plays. I was in the Little Theater in Newark, New Jersey, and so it was all. And I had the first play that was produced at Dartmouth when I got there in that play. It wasn't until I took a course in general biology, which had a reproductive session and a psychology course, that I said, wait a minute, I think I want to be a doctor. Now, there's a long history of doctors in my family. My father and his brother, and my grandfather was the dean of medical school at Dartmouth, and I have brothers that are also physicians. So I decided at that point to go into medicine, and to OBGYN specifically because of my interest in that reproductive physiology class.
Was this where you were at college? It was in Dartmouth?
It was at Dartmouth, yeah.
And where did you go to medical school?
University of Rochester. Now the interesting thing is that although I graduated cum laude from Dartmouth, that was really, Rochester was the only school that initially accepted me. Because I was what we call a senior fellow. And a senior fellow at Dartmouth is one that has an independent study and not involved in any classes. And my crazy independent study was the relationship of religion and medicine. I didn't know enough about religion or enough about medicine to make any headway into that. But I think that because of the philosophy of Rochester, with the influence of the history and with John Romano, the psychiatrist, and the internist, name escapes me for a minute. That whole process and thinking at Rochester in terms of the very importance of the history, and that was the critical thing. That I think that's why they accepted me.
Was there anything in your medical school career that further strengthens your interest in OBGYN?
Not really, because because I had just sort of the general things as a medical student in OB. I did when I was going to be graduating. I joined the Army in senior year because I could get money for that as a second lieutenant. Because by that time we had 2 children. And I had gone to the chair of the OBGYN at Rochester and told him that I would like to come back after my internship and pay back in the Army to have my residency in OB. And he said, well, if you're going to go into the Army and internship, we don't want you back. And so that was the end of that.
So where did you take your residency?
Well, I didn't get it the first year, and so I was a troop doctor for the 82nd Airborne Division, jumping with the troops. And then after that, I was given the option of going to Fort Hood, I think it was, and then to San Antonio for the residency, the first year of Fort Hood. And I said to them, this is crazy. Why send me to Fort Hood and then transfer me again the next year to San Antonio? Why don't you leave me here at Womack, because it's the same program at the Womack Hospital? And they said, well, because of your experience, why don't we send you to, waive the first year and send you to Hawaii for your residency there? And I thought for a millisecond and said, that's fine. So that's where I trained, at Tripler.
You were at Tripler Army Medical Center.
Medical Center, yeah.
All right, now, when you finished your residency, obviously being in the military, you had to be assigned somewhere. Where did you get assigned?
After my residency, I was assigned to West Point. And people say, what is an obstetrician doing at West Point? But we had to take care of the staff wives, plus the Air Force base that's just north of West Point. And we expected to be there for 3 years. After 1 year, I got orders for Japan. And when I knew why, because the young guy that was being trained at Walter Reed was going to be sent to West Point, and both of us could not be there. So when I complained about my going to Japan after just 1 year, I was told, well, gee, you've been there for 3 years, what are you complaining about? I said, well, I just got here last year. Oh, my mistake. Well, if you don't want to go to Japan, we'll send you to Vietnam. And so that was a no-brainer in terms of that. So I was the hospital commander of the smallest U.S. Army hospital in the world, 10 beds, but I had five of us physicians. I was board certified in OBGYN, I had a board certified general surgeon, a board certified pediatrician, and 2 general medical officers. One who was, when he left the Army, was going to go into internal medicine, and one into psychiatry. So how about that for a staff for 2,500 people? That was, and then the post closed, was supposed to close, and so I decided to
Which hospital was that in?
It's called the U.S. Army Hospital Shitoshi.
Shitoshi.
Yeah, and it's in northern Japan, in Hokkaido. And so when I was planning then to leave, I was brought back to Washington to talk to the General Whalen to try and convince me to stay in the service. And because he could not guarantee that I would stay at one post, because that was our problem. Our oldest son was going nuts with all the moves that we had. He'd make a friend, and then the friend would either leave or he'd leave, and so it was a little disjoint for him. So we wanted to be someplace a little more permanently. So I resigned and joined a practice in Manchester, Connecticut.
And when was that?
That was 1970.
What kind of a practice was it?
Well, it was two guys. One had trained at Hartford Hospital, and one had trained at San Antonio in the military. The one who had trained at Hartford Hospital, of course, as everybody had trained at that point in the East, patients were put to sleep. Were given scopolamine for labor, and it was just a wild zoo. The senior partner didn't think this was really appropriate. So he went to France and met with Vallet, who was the disciple of Lamaze, and learned about the Lamaze method. Came back, changed the kind of the character of deliveries at Manchester, turning one of the forward labor rooms into a Lamaze room, hired or got together a group of nurses that we called the monitrices that were on call 24 hours 7, and came in when a couple wanted to have a baby. I was not uncomfortable about dads in the delivery room, because when I was in Japan, and obviously the only obstetrician, one time one of the dads said, "Can I come in?" And I said, "Well, sure, why not?" So it became a thing that in northern Japan, that the dads came in for the deliveries. And the only time I was not happy with them, and I kept them out, is when I gave a spinal for a C-section. I didn't think that they would like to see me put a needle in their wife's back, so I can't.
You must have been one of the very first people in the U.S. to have that type of involvement in a delivery.
I think we were, and certainly the Moz program that we had, Johns Hopkins came up from Baltimore to see our program and to make use of it down there. Of course, it created a little conflict with the Hartford hospitals because we were sort of stealing their patients because we had this program and they didn't. But they wouldn't come over to see what, they went down to Johns Hopkins to see what
see what your program was.
Yes, right, yes. Yeah.
How long did you stay there?
I retired in '98. I had planned to retire at 62, was what I was in '98. And I just happened to have, it wasn't pushed me to retirement, but I got a diagnosis of prostate cancer at that, just a few months before I retired. And that has changed things in terms of what I do now, because I elected to have a radical prostatectomy. I also elected to have not nerve sparing because knowing where the nerves run and where how you had to maybe make not as wide a margin as you would like. A cure was better, and because I knew how to, if I wanted to get an erection, get an erection. So I learned a lot about male sexuality. I had, during the practice, in Manchester, starting out in 1970, this was just after Masters and Johnson, I was frustrated because I didn't know how to help my patients who had sexual problems. I took some courses, Hartman and Fithian, who were trained by Masters and Johnson. I joined the American Association of Sex Educators, Counselors, and Therapists and was certified by them. But then at one of these meetings, the ACOG meetings, it seemed to me it was Ron Pion that talked about Jockey Annan's book on the behavioral therapy of sexual problems with the Plisset model. And this was the savior, because I could then comfortably counsel patients without totally destroying an office schedule.
Let me take you back during this period of time. You obviously had a lot of mentors. Which mentor that you had do you think had the biggest impact upon your life and your practice?
Well, I always, when I contribute to the college, I always do it in memory of John Olynyk, who was the chairman of, actually he was the chairman of surgery at Tripler, because he was the ranking officer as a colonel in the department of both OBGYN and general surgery. And when he would make rounds, what Dr. Olynyk would do would place his hand on a patient so that she was part of the encounter and not somebody that we were just talking about. So I love that aspect of his care.
I remember John Olynyk. He was actually the physician that took care of my wife for her second pregnancy while I was in the Navy.
Oh, yeah.
Let's move on a little bit. What would you say were the most important aspects of your career now that you're in the twilight of your career and you can look back on it? What would be the things that stand out most to you?
Well, I think that since this is what I'm doing, is that my interest in sexuality and how to handle patients' problems, and then carrying that through, in that I have, besides the talk that I gave today on how to talk to your patients without killing your office and using the Plisset model that Jockey Annan enunciated, that I give talks on sexuality and aging to aging groups. I gave it to in our Sun City Center in Florida, to the church college there. I started out doing that to my classmates from college at reunions. So the first one was the 45th. I did it again in the 55th, and I'm doing it again. I did it last year and doing it again at the Elder Care Center that's associated with Dartmouth-Hitchcock Hospital. And what I do is to try and help us aged in terms of not looking at sex as a single aspect of their life, but a broad aspect. That sex, having sex, you know, people say, did he say it correctly? I was not having sex with that woman. That was the typical idea, that sex was having intercourse. And my feeling is that sex is such a broad range of sex that to think just in terms of that as the only aspect. And so, particularly if you can have intercourse, if you're impotent, you know, then, you know, is your sex life over? Because there's a whole much more to having it.
In this age of Viagra, that's probably a different approach than most people expect.
Well, you know, the crazy thing about Viagra, statistically, only half of the prescriptions are refilled. I think that guys say, it isn't like it was, you know? That's spontaneous, just roll over, honey, let's, you know, you got to plan. And what's the bad thing about planning, you know? We plan all sorts of other things. We plan on going to movies or parties or something, but do we ever sit down and plan about having intimate times with our partner? Rarely.
It's a good question. What would you recommend to a young physician today? It's why to choose our specialty of OBGYN?
I think there's just so much joy. You know, that there's an occasional bad result that we don't. I mean, you have a bad baby, that's a bad result, or if you have a mother that's in problems. And other than a malignancy in a gynecologic practice, but you know, how much do we deal with the malignancy now when we've got specialists in our field that do a much better job of handling those kinds of things? But I think it's the joy of this practice, and the interesting thing is that I think my thinking back early was that we were the dumb ones that went into OB. Now it's the most bright, because you cannot encompass all of this knowledge and all of this stuff that we have in obstetrics unless you've got something upstairs that can handle it. So I think it's a very challenging but interesting and neat. But I don't know, maybe we can make some effects. Some of the speakers this morning, I think, were kind of looking at, can we make some differences in how things are kind of set. I'm thinking particularly of the fact that only one person in my old practice is doing vaginal hysterectomies, and all the rest are doing with the robot. Well, you know, do we really need this technology? And I'm sort of, I know everybody hates the insurance company, but I think United Healthcare has done a neat job in saying, if you're going to do a hysterectomy, you're going to do it vaginally, fine, go ahead. But if you're going to do it any other way, you better, you know, get a permission from us.
Speaking of that, what do you see as the most negative part of our specialty?
I think we too much relying on on technology. And a great example was when we went to our 50th medical school reunion. The dean was talking about how all of the students would be getting an iPad with a year's lecture on the iPad. Great. But then he said the next thing we wanted to do is to have everybody have a remote ultrasound unit. And a classmate and I looked at each other and we said, nobody's going to put a hand on a belly anymore. They're going to put that ultrasound unit. And so, you know, we already know that touching is way down. But boy, if we you know, have the first thing is throw a technology at somebody, that's not going to be helpful.
What do you see as the future of our specialty?
I think that with the changes in on the genetic and molecular level, I think we're going to see a lot of positive things in terms of where we go. I think this. I think on Monday there's going to be a thing on mitochondria injection into eggs, and I think this kind of thing is interesting, and I think will be very helpful in terms of helping patients. I think I would like to see, the fact that our section rate, early on was 4%, and why is it over 30%? And the loss of skill in using forceps or a vacuum extractor is really too bad, and I don't know how we can reclaim that because those of us who were adept at it are retired, and is there anybody left to do that? Except that one person in our practice not only does vag his, but she does vaginal breaches. So I love that.
What else, is there anything else you'd like to add to this interview? How do you see the medicine in general or the specialty?
Well, I just think that we've got to back off on looking at technology as the be-all and the end-all. We've got to get back to thinking in terms of what is the important thing. And I mean, I just had an experience with, I have to have my other knee replaced. And the interview was not asking me why I wanted to have it replaced. It was trying to fill in the gaps. When do you have pain? Well, if I walk over a quarter mile, it hurts. Well, how much pain do you have when you're sitting? I only have pain if I walk over a quarter of a mile. And it went on and on like that. And so this kind of thing where, we've forgotten to say, let's ask the patient and let's listen to her.
I think that's a very good way to end this interview, because I think it's very important. We still have to remember that the patient is why we're there.
Exactly.
Not the computer.
Right.
Sam, thank you very much for coming and participating in this interview and sharing with us. You've had a unique career, and I think you represent the best of what is out there practicing medicine today. Thank you very much.
Thank you. My pleasure.